I have been given the additional responsibility to talk about this 3D assessment of native aortic and mitral valve. Mitral valve function complex, as you know, in addition to the valve, you have the caudate tentonae, subalveolar apparatus, and then the papillary muscles and a portion of the myocardium. So all these things are called as mitral valve apparatus. And the classic view, that is a left parasternal view, is the best view to identify the mitral valve. The aortomitral curtain, you can see here, aortomitral curtain. This is the aortic valve, this is the antemitral leaflet, and this is the posterior mitral leaflet. And just adding the 3D button gives the depth. This is the olden day method of recording the 3D. This is the current technique where you see more clearly the papillary muscles and the subalveolar apparatus. And you have the anatomic view on the right hand side, this anatomic view, and it is lifelike. And you can see the aortic valve and the left hand side. The initial days we had the 3D and the modern this thing. This is the trans illumination. It's called as trans illumination, adding the source of the light. You can see in the center point the light is moving there. You can keep it anywhere and you can see that. So the advantage of 3D is that you can see from top as well as bottom. That is, this is viewing from the right ventricle side. This is viewing from the right atrial side. While viewing from the, left atrial side. While viewing from the left atrial side, you always see the aorta, and then the left atrial appendage comes there. This is viewing from the left ventricular side. You have the papillary muscles cut off. You can see here, this is the antemitral leaflet and this is the posterior mitral leaflet. You see. And current 3D machines have this unique technique of simultaneous display of both the left ventricular aspect and this is the left ventricular view of the mitral valve, this is the left atrial view of the mitral valve. Simultaneously you can see that. And what more is adding light to your programs. That's what I was telling in the morning. This is called as trans illumination by one vendor and fluxy light by another vendor. It is simply a software to keep a light source. You can keep it anywhere. You can move it in the x-axis, you can move it in the y-axis, or you can move it in the depth. That is the trans illumination. This is called as the flexi light technique. This light source can be placed anywhere, can be moved anywhere, so that you see that with ease. You can see that comparison with you can see that this is another technique which is called as glass view, which increases the transparency of these things, so that you see your devices much more better. It's very, very useful technique for interventional cardiologists who is going to apply these techniques. So this is the three-dimensional echocardiography, transesophageal echo. This is a biplane view, and this is the triplane view. So in a single shot, you can have view of all the segments of the mitral valve, unlike the 2D echocardiography where you have the difficulties. You see here, this is 2D echocardiography independently placed and cooked up. Here it is 60 degrees where you can see A1, A2 and P3, and 45 degrees bicameral view. You can 45 to 55, you can have that in bicameral view. Again P1, A2, P3, all confusion comes in. Only thing which is reliable identification of scallops in your 2D technique is your 120 degrees or the long axis view, where you can say definitely it is A2 or P2. Still, even in this, you can see here the lines can be, cutting planes can be different, so that the scallops identification may be very difficult with your 2D technique, which is very easy with your 3D technique. So here, this is the surgeon's view or view from the left atrial side. This is the aorta, left atrial appendage. So from the lateral sides, This is A1, A2, A3. This is P1, P2, P3. So scallop identification is very easy with the 3D technique. And again, you got additional technique which is called as two-click crop. You can just place one click over here, another click over here. Then you see the cut view on the right hand side. This two-click crop. Again, the two-click crop can be placed in this direction so that the commissures, the lateral commissures, can be identified very easily. And this is photorealistic images. Now, in the morning I was showing you the cases of mitral stenosis. So we will concentrate on cases of mitral regurgitation. So in mitral regurgitation, 3D techniques allows you to identify the vena contracta. There is improved accuracy, reproducibility with the NFS view of the 3D color Doppler technique. This very useful um, in during your interventions, MitraClip and other applications. You can have that. And this is calculation of the effective regurgitant orifice area by 2D techniques. Whereas in 3D it is very easy. You can straight away go for anatomic regurgitant orifice area. Anatomic regurgitant orifice area. So these are simple ways. This I will illustrate by a simple case of mitral regurgitation. You can see here this is a simple case of mitral regurgitation. This is the triplane view of the transesophageal echocardiography, and this is the identification of the mitral valve by 3D. You can see here this is the mitral valve. Any spot diagnosis? Anybody? What is the diagnosis? Now, A1, A2, A3, P1, P2, P3. So this is P2. See that it is coming and prolapsing. This sort of appearance. This is P2 prolapse, which you identify as a spotter, which may be very difficult with your 2D techniques. This is adding the light, trans illumination, that gives you this definitive advantage so that this is prolapsing back into the left atrium. And this is what I was telling you. This patient is having mitral regurgitation. So by adjusting the cutting plane or transverse line, this can be moved in, placed at the neck of this regurgitant jet, so that you identify the regurgitant orifice, and very easy to planimeter and get the anatomic regurgitant orifice area. So anything above 7 square millimeter will be our severe regurgitation. This is another technique which is called as the mitral valve quantification technique, which is very useful for surgeons who do the mitral valve repair, procedure for patients with mitral regurgitation due to mitral valve prolapse. So they can do this, where you can develop and analyze the annulus area, annulus perimeter, the AP diameter. So all the requirements, the annulus height, mitral aortic angle, this is very important for the surgeon. And all these measurements are possible with a flash of a second. So that is about the mitral valve. So now coming to the aortic valve is composed of three cusps, which all of us know, and a lot of interest is here in the 3D TE imaging because of the interventional cardiologists who require the transesophageal technique right at their cath lab. So this composed of three cusps attached to the in a semilunar fashion along the entire length of the aortic root, with the highest point of attachment at the level of the sinotubular junction, and cusp form nadirs defining the virtual annulus. It is the virtual annulus. So while doing that, just place the acquisition window. These are called as acquisition windows. Just place it over your region of interest. And on the biplane, this is biplane view. Just you place it here, then analyze it there. Now, TAVR, I was emphasizing, has become standard of therapy, and there is much drive in interventional cardiology circuits to do this structural intervention, which requires transesophageal echocardiography. So, aorta, I mean, aortic valve, again, I told you, can be viewed from the LVOT side as well as from the aortic side. So, both sides. This is short axis image of the aortic side of the level of the cusp are the most useful for determining the cusp morphology and pathology. Again, you can view from the other side, that is the LVOT perspective. The ventricular arterial junction between the ventricular myocardium and fibroelastic wall of the aortic root has muscular and fibrous elements, which includes the mitral annular curtain and membranous septum adjacent to the conduction system. So these can be identified very easily, and you can analyze all these things. The aortic annulus, how do you measure that? That is very, very important because you have to size the valve only on this. In 2D, never 2D measurements never correlate with the CMR, and 3D correlates very well. Let me explain that. The measurement is usually done in mid-systole, that's where number one, from inner to inner border, very important. Now, the left main height, that's also very important for the interventional cardiologist, so that they don't tamper with the origin of the main coronary artery, left main coronary artery. This can be analyzed very easily by the flexi slice analysis, which I have shown you. Just place the center of the point. This point, center point, has to be placed over this, and then you can move this cursor so that left main is measured, and then you can directly measure the height of the left main from the annulus. That's what. So this is the classical view which you get, and simple software analysis tells you that you can do the quantification aortic valve. This is the aortic valve quantification. The aortic valve, aortic root diameter can be measured, the maximal diameter and minimal diameter, and you can find that this diameter is not, this aortic annulus is not typically a circle, it may be oval, so that you have maximal diameter as well as minimal diameter. And this is the bicuspid aortic valve. These are the Carpentier's types. Now, this was one patient who was referred as dilated cardiomyopathy with a severe LV dysfunction. You can see here the aortic valve is markedly thick, calcific. You can see that, thick and calcific. And the gradient across the aortic valve is maximal gradient 53 and minimal gradient, mean gradient 30. This is the 3D planimetry of the aortic valve, that is 0.5. You can do the planimetry very easily with this. This is the ejection fraction calculation, and the GLS calculated right from, this is the transthoracic as well as transesophageal. GLS remains the equal. This will be of help during the intervention procedures. And you have the 3D derived longitudinal strain, circumferential strain, area strain, radial strain, and the twist degrees which can be calculated, which are all reduced in this case. This is aortic regurgitation, and the anatomic regurgitant orifice can be calculated here, and it was 0.4. And this is the aortic annular measurement by these techniques, aortic valve quantification. Now, coming to aortic stenosis, this slide is a very popular slide. Dr. Samir was showing that in the morning. This is a natural history. It's very important. The later period is very long, and suddenly the patient collapses. With the onset of severe symptoms, his mean age of death is less than 5 years. That we have average survival, you can see here. That is the importance of aortic stenosis. There's no medical therapy which prolongs life. There are theoretical benefits of using the statins, but no other use. That is why the importance of the valve replacement, both surgical and medical, transcatheter interventions which are possible. Now, the problem is when to operate or when to intervene. Now, the focus has shifted from the high surgical risk, which was there initially, high surgical risk. These were the patients who were selected for TAVR cases, class 1 indication. And when there is a prohibitive surgical risk, class 1 indication, now again this has moved to intermediate surgical risk, where there is class 2 indication. So whenever there is a low surgical risk, it is always surgery. So that is the way the TAVR is done nowadays. And how to calculate the valve area? The continuity equation is the most important one, which used in calculation of the aortic valve area. And the most important point here is the LVOT diameter. A minimal movement of the aortic valve, placement of the points will alter your annular diameter. This is the comparison of the conventional and 3D technique. This is the 2D valve LVOT diameter. You can see here the measurement comes as 21 millimeters. Whereas here this is the 3D, the same segment. See, same patient, same image. Measurement by 2D is 21 and measurement by 3D is 29. That is the importance of 3D technique in this, and measure the LVOT, and then you get the calculation of aortic valve area, which is very easy. Aortic jet velocity and other things. This is severe aortic stenosis criteria is jet velocity more than 4 meter per second, mean gradient more than 40 to 50, and aortic valve area less than 1 square centimeter. This is the jet velocity and the gradients. There are two groups in this. One is the high gradient, second is low gradient. High gradient is always easy to diagnose. Here the peak gradient is 96 and mean gradient 63. So straight away the patient has an indication for TAVR or surgical replacement. Very easy for these patients. This is fusion with the other techniques. This is the two different ways of assessment of the aortic stenosis. One is the high gradient. It's very easy. You have the classical data to submit the patient for TAVR or SAVR. But the problem comes when there is a low gradient aortic stenosis. And these are the types of bicuspid aortic valve. This tract, high gradient aortic stenosis tract, is considered as an easy tract. High gradient generally indicates severe aortic stenosis. Whether severe high gradient AS is associated with normal flow or low flow or normal ejection fraction or reduced ejection fraction has prognostic implications but does not require further evaluation to confirm the aortic stenosis severity. So only thing you have to exclude the high flow state, that's all, and define go for this. This is one case of bicuspid aortic valve with this is a 3D here, and you can see here the attachment at 1 o'clock and 7 o'clock position, and this is the assessment of LV. We had a elaborate discussion on ejection fraction calculation and utility of the global longitudinal strain GLS in addition to your this thing. This patient bicuspid aortic valve with severe AS underwent the balloon aortic valvuloplasty, and this is to post balloon aortic valvuloplasty results. Residual gradient was reduced to 42, mean gradient 23. And coming to second case, this is aortic maximal gradient 93 and mean gradient 54, and ejection fraction was 52%, and this is high gradient aortic stenosis, and the GLS is minus 17. So these are the areas where there is clear cut agreement. Now coming to low flow, low gradient aortic stenosis tract. Here, the next step must always be to assess the aortic valve area. Effective aortic valve area calculation indicates moderate aortic stenosis when it is more than 1 square centimeters. So you have to find out whether the aortic stenotic valve area is less than 1. Exclusion of the measurement errors and other things are important. So if it is aortic valve area is less than 1, and you have to exclude the measurement errors and define the low flow status. Low flow, that means stroke volume index less than 35 ml per meter square. So you have to find out this. And next thing is the calculation of the ejection fraction. If it is less than 50 and more than 50. If it is more than 50, there is an integrated approach which you have to follow. If it is less than 50, you have to submit the patient for dobutamine stress echo and look for flow reserve to exclude the pseudo-severe aortic stenosis and to identify true severe aortic stenosis. So you do the dobutamine stress echo with the standard protocol which is available. The starting dose is 2.5 to 5 microgram, and then increase the dose every 3 to 5 minutes, and the maximum dose allowed is only 20 mics. And positive dobutamine stress echo, there is an increase in effective aortic area to final aortic valve area more than 1, suggests stenosis is not severe. Severe stenosis is suggested by an AS jet velocity which increases, as was shown in one of the cases in the morning session. Absence of contractile reserve is a predictor of high surgical mortality and poor long-term outcome. So I will elaborate on case where I used treadmill exercise test, not the dobutamine test. This is a case of aortic stenosis. You can see the calcificative valve associated with the MR, mitral regurgitation, and poor LV function, and reduced GLS. The transaortic gradient, mean gradient was only 22, as you see here. This is the ejection fraction of 38% in this case, and this is the after the treadmill exercise, the gradient increased. The mean gradient was 36 and the peak gradient was 59 in this patient. So the patient was referred for surgery, and these are the various valves. And most important thing is assessment of the paravalvular leak during the TAVR procedures is very important. And you can simply identify the regurgitant jet and go for the calculations and other things. I will just demonstrate how do you assess the native mitral valve. First of all, I will show you this. This is a case which I have shown you already, where I will demonstrate how to use this some of the latest techniques for the identification. So this is the classical 3D view. You are viewing from the left. This is the eye. This you are viewing from the left atrial side, and you have the A1, A2, A3, and this is the P1, P2, P3. And this is the HD live high definition view, where you are able to see the P2 prolapse very easily. Now this is the technique which I was telling you. This is the flexi light. See, I have added the light source. In the center you see this light, This light depth can be increased, depth can be altered, or you can add light. And the light source can be moved from left atrial side to the left ventricular side, and you can identify that very easily. Now, coming to the measurements, you can choose the valve, and you can go for the mitral valve quantification, and this is the mitral valve quantification. These quantifications are very important for the surgeon to determine the uh, now these have to be placed over the center just above the mitral valve in the left atrial side. You have to move that and then keep it correctly. I'm just showing fastly so that it may not be accurate, it may be time consuming. And end diastole, you have to set the end diastolic frame. You can move the frame little more. Then set the end systole similarly, and then go for setting the landmarks. So that is how you have that. Just I am doing rapidly, and you can have the set results, and you have the results there. And similarly, we can look at the ID valve. So this is the ID valve quantification. First of all, you have to align and then place it exactly in the center, and then LVOT segmentation can be done, and the measurements are available. Annular diameter, maximal diameter and minimal diameter, annular circumference, and the mean diameter can be calculated very easily from this. So these are the ways of quantification of the mitral and aortic valve, which are very useful for the interventional cardiologists. Thank you for your attention.